It's my honor to introduce Maria Michaels, who is a senior public health advisor at the Centers for Disease Control and Prevention, or the CDC. She uses technology to transform data into action in public health and in healthcare. She leads initiatives on adapting clinical guidelines for the digital age and making electronic data more available for research and public health, known as MedMorph. So morphing that data into something usable. We're on a project together related to that. ARC has partnered with that on trying to get that implemented. And she's involved in national and international activities related to computable knowledge and data harmonization and data exchange, including serving as a co-chair of the HL7 Learning Health Systems Work Group, the Systematic Review Data Repository Plus Governance Board, the Guidelines International Network North America Steering Group, the World Health Organization SMART Guideline, and others. And aside from professional activities, Maria loves to travel, has been to all 7 continents, and I hope that in her presentation, she is going to embellish with some photographs of her travels in helping us to understand her topic area. But Maria, it's great to have you speak to the crowd.
All right. My slides got away from me a little bit, but I am gonna see if that goes backwards. This is harder than it looks. All right, I'm just gonna skip the title slide, although I was gonna reiterate that what I'll be talking about today is adapting clinical guidelines for the digital age. Oh, now it goes backwards. All right. So we started with the premise that CDC, again, the Centers for Disease Control and Prevention, that led this initiative, but wasn't the only entity that was part of it, and other organizations. And I randomly chose one called the American College of Surgeons. Not sure how I came up with that one, but all of these organizations develop guidelines, presumably to narrow the gap between current and optimal healthcare. And so we first had to define the problem. Basically, we've already talked about a lot of this. It takes too long to develop and implement clinical practice guidelines, or CPGs. It takes too long to apply that evidence into patient care. They're typically published in lengthy written documents, so this narrative text, whether it's online, in a journal, and those formats aren't easy to access at the point of care. They're not quick to adopt. They could potentially be misinterpreted and may inconsistently be applied in different organizations. And so you can kind of look at this in picture form and think about this long implementation time and why it takes that long time. And when you look at this, you might notice it's a very siloed and sequential approach. For those that are familiar with software development, they call this waterfall. And it starts with guideline development, again, in its own silo. Do your research, put together literature reviews, meta-analyses, et cetera, eventually have your guideline panels put together the narrative, publish it in some way. Even if it's online, it's probably something like a PDF. And then you disseminate kind of this sort of spray and pray approach and hope that the right groups learn about your new guideline or guideline update. Those groups now have to interpret those guidelines. Generally speaking, happens at each and every organization for each and every guideline, oftentimes each and every recommendation within that guideline, again, for every practice or hospital for which this guideline might apply. And oftentimes they eventually create sets of tools. Sometimes that's clinical decision support that gets incorporated into the EHR. Sometimes it's various other tools and trainings, but each and every organization does this unnecessarily redundantly. And oh, guess what? The interpretation isn't the end of it. They also then have to implement the guidelines. So now they've interpreted it, maybe created some tools, but now you actually have to put those tools into the EHR, into the hands of the clinicians or patients or whoever they apply to. You have to train them on those tools and how to use them. So again, a lot of unnecessary redundancy, a lot of siloedness and sequential happening that causes that long implementation time. So what we did was we brought together a whole lot of different participating partner groups, and we really try to think about it holistically from beginning to end, soup to nuts, guideline development, really systematic review or evidence generation, all the way to implementation, and even thinking about how do you learn from those implementations to then inform guideline updates. So I'm not going to read you this bulleted list, but you can take a look while I keep talking. And I'll note that we started this more on the national level, and then through a strong interest from international communities, we started becoming more global. And we even count as one of our partners the World Health Organization. And so you heard this term from Mary just a little bit ago. In fact, this was a total accident, but I'm actually citing one of the same articles that she just included in her slides. This concept of computable guidelines is really about a representation of written guideline recommendations in a computable, interpretable format. And these computable guidelines really provide a means to share recommendations in a consistent and more easily implementable way. So for example, within those EHR workflows. And the idea is to have something that is shareable and interoperable that you can disseminate once and be implemented the same way as much as possible, allowing for local, like appropriate local variation. But it should quicken that implementation time. So just to kind of take this a step further, you can think about computable guidelines like MAPs. The written recommendations, which you're all, I'm sure, familiar with, fits into this L1 or narrative level of knowledge, which is analogous to a print map. So you might remember those road atlases from back in the day. I know my parents pulled those out for those family road trips. Totally static, doesn't change, very hard to find what you need, but it's there if you look. L2, or the second level of knowledge, is more semi-structured. So we're getting progressively more structured in the information. And now you can think about things like flowcharts, decision trees, inclusion, exclusion criteria. And those are analogous to static digital maps. So if you remember a time when they used to hand out maps on a CD, that's kind of the analogy to the semi-structured format. Now we get to the computable recommendation, the L3 or structured level of knowledge. And now we're really talking about those computable algorithms. And those are more like the executable digital maps, similar to mapquest.com or google.com, where you go in and plug in a beginning and end address and tell it to give you a route. You have the beginning and end, and it does execute a route, but it doesn't change based on a context. You just have the beginning and end, and that's all you have to go by, which is what brings me to the L4 executable level of knowledge, which does take context into account. In this case, you can think about things like clinical decision support that take a patient's context into account. So not only do you have that computable recommendation, but you also pull data from the patient's record into that algorithm so that it gives you a more personal recommendation based on what's happening with that patient, the information that we know about that patient. Just like GPS changes your driver based on your driver's context, right? So if you run up against a detour, if you hit traffic, if there's an accident up ahead, the GPS will reroute you or possibly recommend some additional options based on that driver context. So I did sit through listening to some trauma acronyms, so I felt like it was only fair that I throw some back at you. And I even misspelled the word FHIR for you. FHIR stands for Fast Healthcare Interoperability Resources. If you haven't heard about this yet, I am sure you're going to hear about it soon. It is finding its way into a lot of federal regulations here in the US. And we created one related to computable guidelines, or really computable knowledge, but because guidelines are like the big major piece of knowledge that we're looking to make computable using standards, it kind of took the name, right? So FHIR clinical guidelines, which we call CPG on FHIR, what is established through HL7, Health Level 7, which is an international standards development organization. And I'm not going to go through all the details of how, this balloting process, but just know that that's a typical standards maturation process that includes vetting from the international community in this case, because this one is an international standard. So that one is kind of the basis for the interoperable piece of what I've been talking about. And we also published a journal supplement, which we were really creative in naming. We called it Adapting Clinical Guidelines for the Digital Age. Same as the initiative, it is open access, so everybody can read every single piece of this. And I won't go into detail about all the articles, but we do have kind of starting from the top, a really high level leadership summary, overview of the initiative. For those of you that do develop guidelines, there is sort of a step-by-step, if you will, process, which we call the integrated process for co-developing written and computable guidelines, and then an evaluation framework for how to evaluate that integrated process. And then we actually adapted something called Kaizen. If you're familiar with the lean methodology, Kaizen is a tool that's typically used in business or manufacturing. We adapted it for these large, complex, multi-organizational processes like guideline development and implementation. So if you want to read more about that and potentially use it for other things, we have an article for that. And so what did we do as part of this initiative? Well, we looked at that waterfall approach, that picture that I showed you at the beginning, that's sort of summarized here on the left in the current state. Again, very sequential and siloed, where one thing has to happen, then gets released to the next thing. You hope that there's no mistranslation. I often give the other analogy of the telephone game. Like oftentimes I kind of think about this process as playing the telephone game where somewhere along the line, something could potentially get misinterpreted. And oh, by the way, once you get everything into patient care, evaluation isn't very consistent. And even the clinical quality measures that many of you have to report to various entities, including the federal government, those are often treated separate by your organization, by the healthcare organizations. So we really have these incomplete, sometimes non-existent feedback loops back to the guideline developers. So again, that long list of partner groups all got together from their individual perspectives, put our heads together and said, well, what if we make this a more parallel and iterative approach? What if all of the perspectives are represented up front at the outset and work together in an iterative way to develop and implement the guidelines? And with respect to implementation, we've actually represented a lot of those perspectives here today when we talk about representing the patient perspective, the caregiver perspective, the rural perspective. So you really got to think about all of the different perspectives that are important for implementation when you think about that implementation perspective. But then there's the scientific perspective represented by the word guidelines, informatics, which is more about structuring and making complete the knowledge that is needed. It's not really about the technology. Thinking about communicating the information and again, evaluating so that you have that closed feedback loop. But in this case, we don't want to just have a feedback loop at the end. We want to think about evaluating the whole way across the process and all the way from the end back to the guideline developers. And then in the context of a learning health system, and when I say learning health system, I'm thinking about this sort of virtuous cycle of evidence to guidance to action to data back to evidence again. You really want to be able to piece together information and data from sort of one quadrant of this cycle to the other. And you need common standards to be able to do that. And this is where the Spire standard comes back in. And there are actually standards that are already in existence that can support all parts of this cycle, but they're not yet implemented as fully as they need to be. So again, something that is coming at you if you haven't already experienced it in your own organization. You can think about these standardized structures like Lego blocks. So similar content can be represented by the same block type. Different block types can be configured in specific arrangements for each type of knowledge. So you can have a configuration that represents evidence, guidelines, measures, case reports, and so forth. But really, it's the same group of Lego blocks for any particular set of guidelines or recommendations. And then the standards for each of these types, as I just mentioned, are already in existence. They're being further developed and matured. So they're coming to a healthcare organization near you if they haven't already. And this concept includes thinking about it as one translation, one faithful representation of the recommendations that could be implemented in many different ways. So again, taking that set of Lego blocks, the computable guideline or computable recommendations, and implementing them by reconfiguring them into case reports for data collection, measures, clinical decision support services, and so forth. And just to say how this might work for trauma guidelines, I just borrowed 3 specific ones from a particular surgical society, and thinking about how those could be made into computable guidelines where you have measures that can be implemented in EHRs. Think about the various dashboards you might have at your disposal, measures that send data to registries where maybe the society is looking at the data in the registry and so forth. The decision support, I won't get into the details of different ways that can be implemented, but it's not just those interruptive alerts that everybody thinks about. There's different ways they can be implemented, including in the EHR, in apps, in patient portals, and so forth. So just really thinking about different ways you can structure the information and disseminate it in a method that's the most useful. And I'll leave you with the question that a lot of people often ask when you start talking about anything computable. Well, can you use AI for that? So I thought I would leave you with what the World Health Organization, or how the World Health Organization is thinking about this. Again, they think about those same 4 levels of knowledge that I mentioned earlier, and they throw in a 5th one that they call dynamic. And this is where the precision medicine piece comes in, where algorithms can be taught to follow the data and be able to inform the guidelines themselves, how the guidelines are applied in certain contexts, and so forth. But I'm not going to get into too much AI here, because I think somebody's going to come up behind me and tell you a little bit more. So I'll stop there, and thank you very much for listening.
We do have time for a couple questions.
Hi, Julia Coleman. I'm a trauma surgeon at Ohio State. I'm here representing the Associate Fellows of the American College of Surgeons. Thank you so much. One question I have, and you may say I'm going to defer to the next presentation, but I'm curious with this concept of computable guidelines. One thing that I think the trauma community struggles with is that we have several different organizations that are creating guidelines, sometimes in the same areas. And so it becomes unclear, like, what is the unified voice in such a setting. And so I'm wondering if the CDC has explored the concept of using that same idea of computable guidelines for creating like computable consensus and pooling those guidelines together to create like a super guideline, for lack of a better term.
So we haven't done it exactly in the way that you're describing, but that would be great if we could come up with like a repeatable way to do that without a lot of medical societies just not being happy about the approach. We specifically currently have a project with cervical cancer screening and management that takes into account 8 different guidelines and puts them together into a single set of clinical decision support rules and quality measures that are based off the same computable recommendations that are, again, kind of looking across those 8 guidelines. So that's kind of our first attempt at actually doing exactly what you said, but we haven't done it in kind of broad way yet. We're hoping that this will be kind of an example to follow.
Hi, Eric Van Eaton, trauma surgeon from Harborview in Seattle, Washington. There might be an EHR vendor that has not fully embraced the open API world of SmartFire resources. Has the CDC encountered any vendor like that?
We might have heard of at least one.
Their
one pretty big
initials
one.
are
Yeah.
Epic's
Yeah.
Corporation.
Yeah.
What's
Without
the
naming any-
CDC's experience there and approach?
So we work with our federal partners because we don't have all the levers. Our levers are primarily with state, local, tribal, and territorial like health departments. That's what we fund the most. We don't typically fund healthcare organizations or EHR vendors, but we do have partners in the Office of the National Coordinator for Health IT and the Centers for Medicare and Medicaid Services that do have levers that can affect, at least in part, some of that. You may remember something called meaningful use. That was a big lever that both of those agencies used in order to, well, that one was really to compel the use of electronic health records, which actually companies like that actually benefited from. So right now, that's the primary way we're working on using the levers that we have to push forward the standards. If we don't have another question, maybe I'll make one other comment. So in addition to your question about the sort of, I'll just call it multiple competing guidelines for lack of a better term, kind of coming together and coalescing for implementation's sake. The other issue at hand are multiple chronic conditions, or really multiple conditions, because there are probably very few people in the world that have zero or one thing wrong with them that you're trying to work on as a physician, no matter what the specialty, or even maybe even especially in primary care. So that's the other challenge, is when it's not even just the same like discipline, it's across disciplines, and trying to think about how those might impact each other, how they need to prioritize. So that is a challenge that we are working globally to figure out, but we haven't figured it out. And I will tell you that we are working very closely with the World Health Organization on that as well.
Thank you.